I'm here with Greg Moloney. Greg gave a really, really interesting talk, interesting session on primary desmetorrhexis. These are patients with Fuchs or pseudophakic bullous keratopathy or just a mixed bag?
At the moment, only Fuchs dystrophy. We don't think it's a surgery that's really indicated for pseudophakic bullous at this point. That's mainly because we still think most of the healing is happening from migration.
So just to be clear,
Yeah.
what you're doing is a primary desmetorrhexis. What you're not doing is you're not doing any sort of endothelial tissue or cell transplantation.
No, not at all. That's right.
So before we talk about what the results are and who the patients are and what you found, talk me through the procedure, because it doesn't sound like you're physically doing very much.
I guess it is a much quicker version of a surgery to offer these patients, but it's a step that every corneal surgeon is already familiar with. It's essentially the first step of a DMEC or a DSEC procedure, but done on a much smaller scale. So we think we basically remove with a reverse Hinsky hook and now some forceps the central 3 to 4 millimeters of decimase membrane with the guttata attached, and that we think are causing the visual degradation. Take that out of the eye and clear out any heal-on, and that's our surgery.
So that on first flush sounds absolutely terrible. Why did you even think that this is something that would work?
We had, I guess, a lot of corneal surgeons have been observing that the endothelium, which we're commonly taught has limited or no healing capacity, in fact has some. And around the time when I was considering starting this operation, I had a cataract patient who had inadvertently lost the central 5-6 millimeters of their decimase membrane. And I watched that patient heal spontaneously over 2 months. And at the same time, had a Fuchs dystrophy patient with predominantly central guttata causing visual problems. And so it was serendipitous that at the time I was watching this healing happen, that I had a Fuchs patient who was asking me for surgery. But that patient was young and they were phakic, and putting a graft in that eye probably would have induced a cataract or required me to take the cataract, and committed that patient to long-term topical immunosuppression. And I just wondered if there had to be a sort of a better way. And I think several people around the world had the same idea as well at a similar time. So it's not a leap of logic. I think it's one that many people are making and thinking about now. Yeah.
So when you do this procedure and you see the patient post-operatively, what does it look like, and when does it start looking okay?
This is the thing that we know, that if you do this to a group of patients who all look the same, some of those patients will clear very quickly, within a month, sometimes 6 weeks. Some of the patients might clear within 6 months, and then there are some patients who, when you get to 6 months and they haven't cleared, we feel that they are not going to clear. So the problem we have right now is when I'm describing it to a patient that it's hard to know exactly what to tell them in terms of their recovery. We are digging down at the moment onto identifying which factors preoperatively are probably significant for picking the ones who are going to heal quickly, but that work is ongoing.
So and you know, we think I can picture at the slit lamp that if I looked at the central 3 millimeters of the cornea, that would look like an enormous space, but in terms of the total surface area of the back of the cornea, it's less than 5%.
That's right. There's a large physical reserve that increases towards the periphery. So we know that cell counts towards the periphery are much higher than in the center. So even as an analysis of surface area, you've got more cells out there to come to the rescue than we think.
So let me ask you something that you almost certainly can't answer with complete confidence, which is it that there is repopulation of cells? Is it existing cells that are sliding over, or is it some combination of the two?
We saw some really interesting things in the cases that we've done. We feel we've definitely documented, with some certainty, we think we have documented mitosis on confocal microscopy. We certainly have bodies that look very much like...
That's supposed to not happen.
That's right. So we do feel that we have probably documented mitosis in the peripheral population after this procedure. But if you analyse the cell counts over time, what we see is that the central cell counts go from really something unrecordable, because they're all Guattata,
Yeah.
to some number between 500 and 1,000. But the peripheral cell counts will go from, and we only included patients with cell counts more than 1,000, so we were trying to choose people with some reserve. Those cell counts will decline by around 35 to 40%. So we do think that migration, even though we can see what we think is mitosis, cell counts are telling us that it's mainly migration that's doing the job of healing. Yeah.
So this sounds wonderful, and I understand that the great majority of your patients cleared. Why didn't they all clear?
We are unable to say. What we saw was interesting in that we had 3 patients in our surgical series that didn't clear and required salvage measures. All of them made some attempt to clear, so that we could see migration of the cells. And then, for a reason that is yet unclear, the handbrake went back on those cells and they stopped moving. And I have to believe that we're only postulating now, but on a cellular level there must be some signal that these cells are receiving after a certain amount of time. Some inhibitory signal to migration that stops that progress. But we're not sure yet exactly what that is. Although there's basic science work on this, we're not sure how to correlate that.
Yeah, I mean it's really, really wild stuff. I mean it's as if someone were to come in here and say, well, this is how I'm doing cataract surgery. I'm doing a capsulorhexis and I'm sending the patient home. I mean, it sounds like the whole procedure's missing.
There's a critical step that's not there. But
no, this is really, really, really wonderful stuff. I wish you the best of luck for me. Because if this does pan out, and it certainly seems, at least within the patient population that we've studied, that it's going to. This is a tremendous, tremendous leap.
We hope that it's going to expand our pool of graft tissue and provide a visual intervention to patients in areas without easy access to graft tissue.
This is wonderful. I want to thank you very much for bringing this work to us, and of course for being so very generous with your time with us today.